Bismillahirrahmanirrahim. Today we will discuss the salivary tumor. In this today's lecture, I will briefly discuss about the overall clinical features of the salivary gland. And in detail, I will discuss the two benign tumors. My lecture is mostly from the Robin pathology and the surgical pathology, Ackerman. At the end of this lecture, I have some MCQ questions, and hopefully this lecture and MCQ question will help us undergraduate students and the postgraduate students to solve their examination component. Second thing is that we all know that the salivary gland tumors are almost a large heterogeneous component, and the etiology is still unknown, and there are a lot of diagnostic problems. We will discuss these things one by one in detail, and I will expect that at the end of this lecture, you will be able to understand to give the answer of the parotid gland. This lecture is also helpful for the clinicians to treat, to stage according to the stage of the tumor, because the staging is very important. And the third thing is that the lecture is based not only from the textbook, but also few components from the WHO, because WHO has updated few new terminology like secretory carcinoma, like invasive ductal carcinoma of the breast, and the low-grade polymorphous carcinoma, and few other terminologies in the salivary gland. And the next important thing is that nowadays Milan system is becoming popular, and for the early diagnosis by the cytological classes. And another thing is that very little we know about the immunomarker. However, histogenesis and immunomarker can help in the diagnosis of the salivary gland tumor. I hope if you like this lecture, you put your question at the end in the question box, and subscribe this educational activity channel, so that my all lectures regarding pathology and infectious diseases, you can get uh, whenever I update my new lectures. So this is the just you all students know that the salivary gland, we divide the tumor, the salivary glands into two main groups. One is the major salivary glands. You all know this is the parotid, one of the largest pair of this salivary gland, and this is the serous type of the salivary gland. Another is the submandibular glands, and this green is the sublingual glands. This is the serous, this is the mixed, this is the predominantly mucinous. This classifications depends upon their secretions. One group, and other is the minor salivary groups of the hard palates, buccals, front of the on the gums and the lips and the tongues. And so the tumor mostly arises from the predominant area, that is the parotid. Today's lecture will introduce the salivary gland tumors, the epidemiology of the salivary gland tumors in the last 5-year prognosis of the salivary gland tumor, etiology, histogenesis, morphogenesis, genetics, the uh, the distribution of this tumor as the system is 70 to 80% of the tumors are in the parotid glands, and 20% of the tumors are in the minor glands, and 9 in the submandibular, and about 1% in the submandibular gland, in the sublingual glands. And if you see the prevalence of the tumors, salivary glands and minors, again, predominantly there are 55% in the palates, and in the upper lips, 15%, and 10% in each other areas, tongues and the cheeks. What are the different types of the tumors that can arise in the salivary gland? Predominantly, the pleomorphic adenoma, 70%, 80%. There is the rule of the 80s. I will discuss in the later on. Some clinicians believe on it that 70 to 80% of the tumors are the pleomorphic adenoma, and then the mucoepidermal carcinoma, adenomyocystic carcinoma, and other. In Pakistan, same ratio we are looking. One of my students have made the research, and almost similar the result, but consistent to the WHO and other areas. But very important thing is that 80% of the tumors, this is the benign tumor, there the pleomorphic adenoma. Well, the rule of the 80s, 80% of parotid tumors are benign, 80% of the parotid tumors are the pleomorphic adenoma, 80% of the salivary gland tumor occur in the parotid, and 80% of the occur in the superficial lobe. That is very important. And mostly in the major lobe, and very small number in the tail. 80% are untreated pleomorphic adenoma may remain benign. There may be some, the tumor may reappear, and if incomplete surgery is there. If you see this number of the tumor, again, more 40% tumors in the pleomorphic adenoma in the minor salivary glands, and the mucoepidermal carcinoma, again, same. Mostly these tumors are in adults, and but can this pleomorphic adenoma and mucoepidermal can be seen in the children. This low-grade polymorphous adenocarcinoma and certain other tumors like that have discussed in the beginning can occur collectively in the difference between the major salivary gland tumors and the minor salivary gland tumor, they are 80% benign, they are 50% malignant. The general rule is that the smaller the involved salivary gland, the higher the possibility of the gland tumor. The shorties are always naughty. But good thing is that if you see from the last many years, the death rate and the prognosis is, I think, improving. This may be due to important some development of the diagnostic modalities and awareness of the. Unfortunately, in the Pakistan, The patient mostly presents to the clinician when the stage is highest. That is why the prognosis in patients in the Pakistanis are not consistent with the patient other areas. This I will briefly discuss the classification, but I will request all the students of the undergraduates and the postgraduate to see the different terminology from the higher books and the WHO literature. Important information about the parotid salivary gland tumor that almost they comprised of the 1%, less than 1%, and most of them are adult, but can be seen in children, especially the pleomorphic adenoma and the mucoepidermoid carcinoma increased almost 4 times more in the females, except that the Warthin tumor, which is called papillary cystadenoma. Lymphomatosum, this is associated with the smokers and in the males. Smoking may be the etiological agents in this tumor, but still there are so many other theories regarding the Warthin tumors. Again, the FNAC plays a big role in the screening of the FNAC. Little know about the etiology and the clinical staging is important. Then the molecular technique, immunohistochemistry, still slow to catch on for the diagnosis of this tumor. This is again different literatures, different things that how this tumor lies. Let's discuss now in detail the pleomorphic adenoma. Pleomorphic means different morphology. The name was given by the most component of neoplasms of the salivary tumor we discussed in the introduction. It is a benign tumor, nodular areas comprised of epithelium, and we'll see in the morphology. There are so many other names of this tumor, but especially we call it the pleomorphic adenoma. It's composed of the epithelial cells that rise from the salivary gland duct and the myoepithelial stroma. We divide into two component, epithelial and the myoepithelial. The stromal component, mesenchymal components, and the glands. If you see the gland, that is the triphasic salivary gland tumor with ductal cell, myoepithelial cell, and the stromal cell in this one. The stromal cell can be spindle cells, and the myoepithelials may be 4 types of the cell that we will discuss. Most common salivary gland neoplasm and the show the cytogenic, very, very important for the MCQ questions for the students, that HMGA2 that is about 8%, and putative pleomorphic adenoma gene, the black one, has been seen in the 40% of this tumors. The gross appearance is very interesting. I will show you in the pictures. The tumors is a very tan white bone mass with a oscillated surface and may grow to the large size about usually between 2 to 5 centimeters. Epithelial components and the stromal components, the consistency of the gross depends on the relatively amount of the epithelium and the stromal component and the type of the lattice. Although the tumor tends to be well circumscribed, small extension, maybe some partially encapsulated, maybe protrude, but this is not the, for the uh, this tumor maybe The island of the consistency depends upon the component of this one. Sorry, there was a disturbance of the telephone. The morphology depends biphasic appearance resulting from the intimate admixtures of the epithelium. One thing, the most of the epithelial component is the glandular in nature, but foci of the squamous matter. There may be so many types of the metaplasia, sebaceous metaplasia, squamous metaplasia, very common, the neoplastic. That can confuse you that either there is malignancy or something. No doubt the malignancy may arise in the pleomorphic adenoma, but mostly they are the benign. The neoplastic glands have the lining composed of the two cells. One is the basally located cells uh, in myoepithelial and the uh, epithelial cell. The stromal components vary in different shape and maybe myxoid, usually cartilaginous, there may be bone or something else. Heterogeneous component of this one. Uh, Most common tumor, as we have already discussed the age and different clinical picture, how the patient presents. Usually the painless pictures, painless, slow growing mass initially, small in size and being increased, very slow increase in the size. Initially it is movable, but continued growth because more nodular and less movable, recurrent tumor, multinodular fixed on palpitation, maybe on the palate intraorally, seldom ulcerated. This is the picture, and if you see in the cross A, if you see A and B, they're white glistening a bit, this areas. But if you see it's more soft, it's more harder, it's more softer, this big side area. The slow growing, this is pictures in the females and the males. And this is the hard palate, very well circumscribed films. And how to diagnose this patient, especially as FNSE is the immediate tool to diagnose, to screen the patients. Then the biopsy, especially MRI and CT, can help patients. Again, beautiful cross pictures. Morphology I have seen, but let's see this from different pictures. This is the chondroid area, and this is the connective tissue area. This is ductal myoepithelial, so this one. And if you see this picture of the pleomorphic, you are looking at this is the yellowish myxoid area, and there are spindle cells, and there are the epithelial cells. So almost you are looking here three morphology. This morphology, as we have seen in the cross, in the picture C, this is mostly due to the myxoid background. If you see here, this is cytology, this is the sebaceous metaplasia, again, this is the cells, myopithelial cell, and the spindle cells you are looking. This is the solid variant, you are still very difficult to diagnose, mostly comprised of myoepithelium. Here again, beautiful myoepithelial, this is plasmacytoid variants, mixed tumor with predominant. This is the cartilage. You can see it's in bone in certain areas. That is why it is called myxoid. Again, beautiful pictures, myoepithelial, epithelial, and this is the myxoid areas in the background. If this high power view of that was myxoid areas and myxoid cells, do not confuse if there is any mitosis or something. This is again a cartilage and somas on the periphery. This is the capsule. This is capsulated blood vessels and something else. This is the squamous metaplasia along with this picture is again epithelium. This is the myoepithelial cell. This is spindle cells. You should know different morphologies. I have seen this is the myoepithelial cell. This is spindle. So this myoepithelial cell is of different variants. The plasmacytoid, the spindle cells, the clear cells, the unconstituted variant. Different diagnosis is very important to diagnose the polymorphous of low grade black that is negative adenoid cystic carcinoma. Sometime that I have seen in the epithelial myoepithelial carcinoma. This is the new terminology, squamous cell carcinoma, mucoepidermoid carcinoma. You have to take that. The prognosis that depends on the stages. The treatment is complete surgical removal, especially superficial parotidectomy, parotidectomy with preservation of the facial nerve. It's very important. Local enucleation should be avoided, resulting in seeding of the tumor and recurrence. Deep probe of the parotid total parotidectomy is usually necessary. Also, for the preservation of the facial nerve is very important. Submandibular tumor, total removal of the glands with tumor. Malignant degeneration is a potential complication resulting in carcinoma ex pleomorphic adenoma. It's very important. This may arise, and the risk of the malignant transformation is probably very small, 1 to 5%, and that condition will call carcinoma ex pleomorphic adenoma. Once again, the students have a question that what is the terminology used when when the malignancy arises from the pleomorphic adenoma? It is called carcinoma ex pleomorphic adenoma. Once again, the terminology is called carcinoma ex pleomorphic adenoma. It could be squamous cell carcinoma. It could be high-grade carcinoma. It could be any other variant of the carcinoma. The terminology will be otherwise. The MCQ questions: a 2.5 centimeter parotid tumor is resected. The most common molecular alteration of the tumor is a ETV6 NTRK3 fusion MYB MIB-NIFB fusion PLAG1 fusion and PRKD1 mutation. Again, the question, the reply is the C PLAG. I have discussed in the lectures. MCQ question 2. Which of the following state regarding the pleomorphism is true? Carries nearly zero risk after recurrence of the malignant transformation. The characterization by architectural diversity and composed of one single type of the cells is the most common salivary gland tumor of the neoplasm, typically treated with enucleations. The answer is the C. Question C. A 45 years old man presented with 2.5 centimeter slow growing mass at left parotid region. He underwent ultrasound guided FNAC for evaluation. What is the diagnosis? Basal cell adenoma, oncocytoma, pleomorphic adenoma. It's the pleomorphic adenoma. Again, it is the C. Warthan tumor. Thank you very much. We will discuss Warthan tumor in lecture part 2. And once again, at the end, I will ask you if you have any questions. Please ask the question box.